We are live. We are live. We can begin.
Yep. Thank you very much. A warm good evening to all the doctors from the medical fraternity. On behalf of Dr. Reddy's Laboratories, I, Dr. Snehal Muchala, team lead for Acute 1 Therapy, welcome each one of y'all for this live webinar. I'm sure you and your loved ones are safe and healthy during these current trying times. I take the pleasure in introducing Dr. Reddy's Laboratory Limited in front of this August gathering. Well, Dr. Reddy's, or I can say DRL, is a trusted name in healthcare industry since its inception in 1986. Good health is always our goal. Our belief is guided by our principles, that is empathy and dynamism, which provide both guidance for our current behavior and inspiration for our future actions. And moving on to today's topic, as we all know, it is recent advances in the management of migraine. I think we all are aware that yes, migraine is a very common and highly disabling neurological disorder, and it is associated with a high socioeconomic burden. Effective migraine management always depends on adequate patient education to avoid any unrealistic expectations. The range of available acute treatments have really increased over time. So to enlighten us more on this subject, it is my honor and privilege to introduce our speaker for the evening, that is Dr. Ravishankar. Dr. Ravishankar requires no introduction, but I take this privilege to introduce him. He's a consultant in charge of headache and migraine clinics at Lilavati and Jaslok Hospital, Mumbai. So I'll just have his intro slide. So Dr. Ravishankar, sir, is a consultant in charge of the headache and migraine clinics at Jaslok and Lilavati Hospital. He is trained at the Houston Headache Clinic and the City of London Migraine Clinic. He has been on the board of trustees of the International Headache Societies. He is the only Indian to be honored with a life membership to the IHS. He is a recipient of an IHS Special Recognition Award at Boston in 2013. On the editorial board of Headache Currents and is a reviewer for the Cephalgia and Headache. He is the editor of the book Modern Day Management of Headache, Question and Answers. So with this short introduction, I hand over the session to Dr. Ravishankar. So over to you, sir, to take the academic proceedings ahead.
Thank you. Let me just get my screen ready. Thank you so much for the kind introduction. And I hope all of you can see my screen. Is it visible?
Yes, sir, it is visible.
Okay. Thank you, Snehal, for that kind introduction, and good evening and a warm welcome to all of you. And as Snehal just mentioned, migraine is a very common problem in practice. There have been a lot of advances in this field in the last 15, 20 years. But in spite, we still find a lot of patients coming to our tertiary clinic and telling us that I have been to so many doctors, I have done so many tests, nothing comes positive on these tests. Nobody seems to tell me why my head pains. Everybody gives painkillers and tranquilizers, but my headache just doesn't go away. So this is the scenario which we should change. And that is because we today have so many options to choose from, particularly with the launch of the new anti-CGRP monoclonal antibodies in 2018. Our armamentarium has increased considerably. But the fallout of all these advances, unfortunately, have not percolated into practice for the benefit of our patients. So what I'm going to do over the next 40 minutes is to try and outline for you a plan of approach to the treatment of migraine, I will be talking about both the current options and the future options. And I'm fully aware that headache is only one part of your practice. So I will try and keep it simple and practical. So what is going to be the plan of my talk? I'll begin with giving you an overview of migraine and talk about the burden of migraine. And then we'll talk about the expanding spectrum, because migraine, when we were in medical college, was just common migraine and classic migraine. Things have changed considerably since then. Then we'll get into what is the new understanding and the pathophysiology of migraine, because if we have to understand the new treatment options, we need to know what is the basis on which these new options have been devised. Then we'll talk about the acute treatment and the preventive treatment. And I'll tell you finally what is new, the CGRP drugs and the neuromodulatory devices which we have for the treatment of migraine. Throughout my talk, the most important thing that you will have to understand is no two migraineurs are alike. Every time you will have to plan your own treatment and take a different path. And so we'll talk about the unmet needs, or we'll have to think about the box when planning treatment for every patient. Talking about the burden of migraine. Now, this is from World Brain Day of 2019, when the World Federation of Neurology and the International Headache Society, they came together and felt that it was time to raise the awareness for migraine. And those who spoke on that webinar were heavyweights in their field. It was Professor Bill Carroll, who was the president of the World Federation of Neurology, Professor Lars Edvinsson, the man who gave us CGRP, and Professor David Dodick. And what they said was that migraine is a common, highly disabling, legitimate neurological disorder. The word legitimate is very important here. That affects across all ages, across all races, and socioeconomic classes. There's a high prevalence, more commonly seen in females, it's about 18%, and in males, it's about 6%. And it affects during the peak productive years of their life, between 25 and 55. There's a huge economic burden where it's measurable, like in the States, it's about $27 billion annually, both due to episodic migraine, which is migraine less than 15 days per month, and chronic migraine, which is migraine more than 15 days per month. In fact, if you look at the WHO figures, where they have calculated the years lived with disability due to migraine, it's the second most disabling neurological disorder. But in spite of all these figures, you find that most often migraine is underestimated, it's underdiagnosed, and it's also undertreated. Now, what exactly is included under the headache of migraine, or what is the migraine spectrum as we should be looking at it in the year 2018? The ICHD-3 was launched, and after that, we have not had any subsequent additions. And this is the way you should be looking at the different subtypes of migraine. Why this is important to know the different subtypes is because you will be choosing different drugs according to the subtypes. And rather than going through each of these, I would just talk about what has changed. So what we were calling common migraine should now be called migraine without aura. What we were calling classic migraine now becomes migraine with aura, of which there are 4 subtypes. And then what we were calling as basilar migraine is now known as migraine with brainstem aura. Chronic migraine has acquired a status of its own, It has a rubric of its own, 1.3 as it's in the classification. Then you have complications of migraine. And then when you don't have all the criteria being fulfilled, but it still looks like migraine and you still got to treat it as migraine, they call it probable migraine. And then you have the episodic syndromes, which are seen more often in children. So in order not to overload you, I'm not going into the details, but suffice it is for you to know that you have to use different drugs. For example, you would be treating prophylactically menstrual migraine differently from sporadic hemiplegic migraine. Migraine with brainstem aura needs differently to be treated differently. Vestibular migraine needs to be treated with a different drug. And when you have a prolonged aura or migraine with aura, you would prefer to use an anti-epileptic drug which works on the cerebral cortex. So therefore, it's important to know that migraine is much more than just common migraine and classic migraine. What is new in the pathophysiology? The important take-home message in this slide is that migraine pathophysiological understanding has progressed so significantly that we should now stop using the word vascular, because migraine is now known to be a brain disorder, and the vascular changes are secondary epiphenomena. In the 19th century, it was thought to be akin to epilepsy, a nerve storm, and this was how Edward Leaving in his book wrote that migraine is much like epilepsy. And then Harold Wolff in the 1940s came up with his vascular theory based on his experiments with ergotamine. And he said that it's the vasodilatation which causes the pain, and it's the vasoconstriction which causes the aura. But then subsequently, we had cerebral blood flow studies being done from Copenhagen, which showed that there was no correlation between the clinical symptomatology and the blood flow studies. And so therefore they debunked the vascular theory. And in 1985, this is Mike Moskowitz, the man from Boston, who gave us the perfect understanding by describing the trigeminal-vascular system. We will talk about this in detail a little later. So he was the first one who outlined that the trigeminal nerve is the most important to convey the pain from the periphery to the center of the brain. And this is called the trigeminal vascular system. And so now migraine is perfectly well understood to be labeled a brain disorder. So we now call it migraine a neurovascular, and the vascular changes are secondary epiphenomena. So when you see a patient of migraine, and quite often I still find a lot of people writing diagnosis is vascular headache. If all of you would refrain from using this terminology and would go on instead to write neurovascular, everybody would know that you know and understand what migraine is all about. So I would request you to change the terminology in your prescription papers. So now, how does this new understanding affect us for today's talk? So now we know that migraine is a genetically inherited tendency. The seat of origin of migraine is still debated. Is it the cortex? Is it a cortical hyperexcitability? Or is it an abnormal brainstem function? Even the pundits debate this considerably. But both the structures are involved. There's also involvement of the hypothalamus. The pain of migraine, however, with which we are more concerned, is a peripheral origin. So therefore, you have to understand that the brain cortical spreading depression initiates through activation of the trigeminal vascular system. TGVS here is trigeminal vascular system. The blood vessels in the meningeal region, and when the blood vessels dilate because of the release of neuropeptides, and CGRP is one of the important neuropeptides which are released. It is an important vasodilator, and it produces what is called a neurogenic inflammation. And then pain signals are sent from the periphery via the trigeminal ganglion to the trigeminal cervical complex in the brainstem. That is where it is called central sensitization. And from then it goes upwards to the thalamus and to the cerebral cortex where the pain is perceived and the headache is felt. So this is, in short, the origin of the migraine in the brain structures, the pain coming from the periphery, coming back into the trigeminocervical complex and getting into the pain areas of the brain. So now, where does the current understanding or the excitement, why was this word recent advances added to the title? That's because we now have a lot of excitement in the field of migraine. And in fact, migraine management is on the move. The landscape is changing. And in fact, this is one of the most exciting times to be working in the migraine field. And this picture you see here on the left is that of Lars Edvinsson, the man from Sweden who gave us the CGRP drugs. And he was the first one way back in 1980 who first postulated and hypothesized that CGRP levels have an important role to play in migraine. CGRP levels are elevated in migraine. And he, along with Peter Goadsby, when they stimulated the trigeminal ganglion, they found that CGRP levels were raised. And so they felt that attacking this and bringing down the levels of CGRP, that is targeting the CGRP receptors or the CGRP ligand, the protein itself, would definitely reduce the vasodilatation and would definitely help in migraine. And thus was born the attempt to attack CGRP. And that's why we first had the oral CGRP, the Gepants, and then we now have the parenteral anti-CGRP monoclonal antibodies. So therefore, we now have a lot of drugs targeting CGRP. And so the difference is that we now have migraine drugs working through the specific migraine pathophysiological derangement to treat migraine. Till now, what did we have? We had drugs which we borrowed from other areas. We had antihypertensives like propranolol. We had anti-epileptic drugs. We had antidepressants. They were at the forefront of migraine treatment. And in future, we are going to have targeted migraine treatment. And that is where the excitement is all about. And in due course of time, as more and more neuropeptides are being targeted, the next to be targeted is PACAP 38, pituitary adenyl cyclase, which is being researched. And once that is targeted, you will have more drugs. So this is what we will be talking about in addition to discussing the current preventive treatments, because we got to go with what is available to us today, and we got to wait for these drugs. They are already being used in the Western world, but we need to wait for them. Shortly, you will find them being launched. Hopefully, Dr. Reddy's also will get into this area. So now, to summarize this part of the talk, if I was asked to bring out a definition of migraine today, I would say that it is a genetically inherited, paroxysmal, triggered, complex, phasic, chronic episodic, neurovascular syndrome, comprising attacks with symptoms beyond headache. Headache is not the be all and end all of migraine. You get quite often you are faced with patients who have symptoms other than headache, and the attacks vary in their expression from patient to patient and from episode to episode. I wouldn't mind if any of you would like to copy the slide, because this is a complete definition where I have spent time on thinking about each and every word, and it sort of encompasses whatever we see in practice. And this is the way I would ideally define migraine. Now, with that introductory backdrop, a few slides to talk about the clinical scenario and what we see in practice before we go on to discussing the treatment options. Now, when you see a migraine patient, what are the top 10 essentials you need to be able to diagnose migraine conclusively? One is you need to remember that migraine is a highly heterogeneous disorder. No two migraine patients are similar, whether it is the clinical features, whether it is the triggers, whether it is the drugs they respond to. And when I mention triggers, you find a lot of patients, they go to the internet and Google gives them a long list of drugs, a long list of factors, and they think that is the cause of their migraine. And the trigger list they bring to you is inclusive of chocolates, cheese, and red wine. These are hardly the items which are consumed in our country. So therefore, you have to understand that triggers are different for every patient. The clinical presentation is different. You have mild migraine, moderate migraine, severe migraine. And sometimes when you wonder why all patients do not improve with a particular drug, you have to understand that it's a heterogeneous disorder. The second important thing to understand is that it is not enough just to treat the attack alone. Migraine is a long-term disorder where you have to prevent future attacks and you have to reduce the severity of future attacks. So many a time patients come and tell you that every time I have an attack, I go to my doctor and take an injection. And that's what I do. And I've been doing that for 3 years. But that's just not the right thing to do. You have to use a prophylactic in the background in order to treat the disorder. You have to disease modify migraine treatment. You are just treating the attacks. It's not enough. Migraine is not difficult to diagnose. If you understand that it is the only disorder with headache, presenting with headache, which has a core theme that runs through different phases. And these phases, if you ask the right questions and you recognize the phases correctly, then you will be able to diagnose migraine clinically. Migraine is to be diagnosed by inclusion, not by exclusion. Because it doesn't fit in elsewhere, you should not be labeling it as migraine. It has to be diagnosed by inclusion. Because as of now, as of today, migraine is still a clinical diagnosis. We don't have biomarkers for migraine. So therefore, it is important to take a good history, recognize the core theme, and come to the conclusion that what you're dealing with is migraine. It can have multiple presentations. Migraine can quite often look like sinus-associated headache. Migraine can present in about 75% of migraine patients. That's a huge number. You can have associated neck pain. And when there is neck pain to begin with, or neck pain terminally, one tends to think it is tension type headache and not migraine, particularly when there are other accompaniments are absent. We have talked about the expanded spectrum. We are going to talk about what should be conceptualizing chronic migraine, because that's what you will see as neurologists and as consultant physicians. You will not be seeing the naive migrainer who has episodic migraine. Quite often you will be seeing patients who have headaches that don't go away. And so therefore you need to understand chronic migraine. You need to recognize that excess use of acute medications like the Triptans and ergotamine can lead to medication overuse headache. Some migraines may be very difficult to treat. The special situations are children with migraine are not littler versions of adults with migraine. They're quite different. And migraine is comorbid with a number of psychiatric disorders. It is comorbid with stroke. It is comorbid with epilepsy. So therefore you need to be aware and look for these comorbid disorders. And then the complicated episodic syndromes, which are often seen in children, which present not looking like migraine. And lastly, sometimes you will have to be sure that the migraine you're dealing with, particularly when it is on the same side, when it is what is called a side lock migraine, you need to be sure that you're dealing with, you need to image the patient to make sure you're not dealing with an underlying structural lesion. There could be some controversial entities which we will not be discussing today, but these are the top 10 areas which you would cover when you're dealing with migraine. I talked about being able to recognize the core theme of migraine. That is the attack sequence. Every migraine patient has to go through one of these different phases. It is not necessary for all the phases to be present in every patient, but usually there is a prodromal phase, followed in some patients by an aura phase, and then you have the headache, then you have the resolution and the postdrome. And this is the sequence which usually migraine patients go through during an attack. Now, it has been established through functional imaging that every phase of this is correlated with a different area of the brain where there is a particular involvement, particularly in the prodrome, you have hypothalamus being involved. In the aura phase, when it is a visual aura, you have the occipital cortex being involved. And then in the headache phase, usually you find it's the periphery and the brainstem being involved. You could have patients manifesting with accompaniments, cutaneous allodynia. And finally, in the postdrome, you will find that patients recover gradually. So if you ask the right questions, you will be able to recognize the presence of these phases and diagnose migraine. Lastly, you have to remember that migraine is a headache plus syndrome. So don't go searching for only the headache or diagnose based on the headache or the visual aura. You can have other accompaniments, particularly hypersensitivity phenomena, photophobia, intolerance of light, sound, and intolerance to smells, dyspeptic complaints. A good percentage of migraineurs may have some watering from the eye, some running of the nose, autonomic features, but it would not be as dominant as in cluster headache. There could be confusional phases. In an acute attack, you might have migraine patients getting confused. There could be giddiness. There could be a syncopal drop attack. And usually you find patients having a family history which is positive for migraine headache. Triggers, links could be there, but about 30% of migraine patients may not show the triggers, may not display the triggers. There could be a connection with the hormonal phases of a woman's life, with sleep and occupational habits. And you should not get confused with disorders like sinus headache and tension type headache. Now, what are the special situations which I talked about? Children do have migraine, and pediatricians might be missing the diagnosis. It doesn't look like migraine in adults. Children have shorter attacks. They usually are bifrontal. They don't have much of headache in the temporal region where adults have. And usually it's bilateral. Adults have much more unilateral. It may not manifest with the same pulsating, throbbing headache. The accompaniments may be different. Children may manifest a lot of abdominal complaints. Abdominal migraine is seen in children more often than in adults. And the episodic syndrome, the variants that you see, are more often seen in children. When we say that women have more migraine headaches, you will have to understand that it usually starts during menarche, around the ages of 12 to 14. Pregnancy, a lot of migraine patients may improve during pregnancy, but some of them may worsen. It usually worsens after delivery and around menopause. And it is wrong to think that migraine is not seen in the elderly. 10% of our migraine patients are beyond the age of 40. So late life migraine accompaniments are usually seen beyond the age of 60, where you have to rule out a vascular disorder when the migraine patient in that age group presents with migraine with aura. And as I mentioned, always be alert to the possibility of a comorbid disorder, because then you can choose your prophylactic correctly. For example, if a migraine patient has a history of a seizure disorder, the first drug of choice would be an anti-epileptic drug. So it gives you an opportunity to treat two disorders using one drug. That's the advantage of knowing about the comorbidities. Now, we are quite often used to thinking of migraine as an episodic disorder because that's the way it was taught to us in medical college. But you have to think differently. You have to understand migraine as a chronic disorder with episodic attacks. And the attacks keep changing throughout the lifetime of a patient. So do not get stuck into thinking that what starts off is the same way migraine presents throughout a patient's life. Why I say that we have to look at migraine as a long-term disorder is because you have a genetically inherited vulnerability. You have an environment which stays the same. The temperature, the weather in India is going to stay the same. The trigger factors are the same in the patient's environment. You don't still today have the perfect prophylactic drug. And since a lot of patients persist and progress, and you have comorbid disorders, you have migraine as a highly debilitating, pervasive, disabling disorder, you will find that if you don't treat correctly, and if there are risk factors, then what starts off as an episodic migraine will eventually progress with an increase in frequency and severity. And when the patient comes to you and says that I've never seen a doctor, I've not been treated with any drugs, and to prevent my attacks, you will find him coming up to you with chronic or refractory migraine. And this is the chronification that you need to prevent from happening by treating episodic migraine at the earliest. Now, chronic migraine is when we have patients coming to us with headache on a migraine headache on more than 15 days per month for more than 3 months. I will correct myself. It should be headache, not migraine headache. Headache on 15 days per month for more than 3 months, out of which at least 8 days are migraine headaches. So therefore, it's any headache for 15 days per month, and out of which 8 days are migraine headaches. Then you use the label of chronic migraine, provided you have ruled out all other disorders. And when I talked about medication overuse headache, this is an entity which is quite often missed in practice. It is a patient who starts off episodically with migraine 3 or 4 times or 5 times a month, takes analgesics, and when the frequency increases, he takes more analgesics. So he has a migraine disorder, a primary headache disorder. He starts using more of acute treatment, does not use preventive treatments. The frequency increases. The presentation changes from a pure migraine type to a combined one with migraine and tension type headache-like features. And you will find that when they come to your clinic, they have chronic headache, and that is called medication overuse headache. So when there is a regular intake, more than 2 to 3 days per week of codeine, ergotamine, or triptans, and the patient's headache worsens, and he has numerous other constitutional features, and he becomes. Why is this important to recognize? It's because these patients who have medication overuse headache, they do not respond to preventive treatment, which you are going to use. So quite often in practice, be alert to the patient who comes and tells you, I take ergotamine tablets about 20 times a month. I take a triptan practically every day, but I don't know why. I take so many prophylactics, but nothing seems to work. They will not work unless you stop the offending drug and then start the prophylactics. Then you will find that same prophylactic which did not work starts now working. So this is an often missed entity in practice. So please learn to recognize medication overuse headache, where particularly when there are combination analgesics which have a lot of codeine. Coming next to the treatment of migraine. Now, this is the main part of our talk, and we are going to talk about treatment. Now, what is the approach to treatment? You have to draw up a plan. You have to first understand that every patient, it's like a tailor. He has to measure up every patient in order to stitch the suit. So you have to individualize and customize the treatment of every migraine patient based on so many factors. For that, you need a rapport with the patient. You need to explain to the patient and build up a sort of situation where the patient gets to like his doctor. And once that is done, because usually if you are in a very busy practice, you may not have time to spend to build up a rapport with the patient. So for headache patients who are seeing you after having seen a lot of other doctors, try and establish a rapport. Every migraine treatment has 3 pillars. One is lifestyle control measures to be controlled and trigger factors to be controlled. Very essential. So that's uniform in everybody. And then you have to choose the right acute treatment which works. And that's also the same. But what is different is what we are going to talk about today, the preventive treatments. And preventive treatments could be pharmacological, could be non-pharmacological, could be nutraceuticals, and you have some which are currently available and some which are going to come in the next 6 months to 1 year. So those are called future treatments. A good combination of all these 3 pillars is what is going to get you out in the treatment of your migraine patient. So the take-home message of this slide is that no one size fits all. Every patient of asthma or every patient of diabetes might have the same treatment, but every patient of migraine does not have the same treatment. Patient education. Why explain to the patient what you're going to do? That's because you need to be transparent in order to achieve compliance. If the patient has to stick to you and come and follow up with you and get better through your treatment, you have to tell him what exactly you can achieve. First and foremost, please tell him that there is no cure anywhere in the world today for migraine. You're all the time talking about controlling his headaches, managing his headaches, and at best you can achieve 60 to 70%. You are not going to be able to achieve 100%, even in the best of circumstances. The second important point to convey is that it's not a course of treatment that you are going to be administering. It is a disorder which has a design where it starts young and comes down with age, and therefore you are talking of a long-term treatment where you are going to be able to reduce the medications as the patient goes on improving. Some migraineurs might need just one drug in the background. Some migraineurs might need more than one drug. And finally, you are also keen to reduce the medicines as the patient improves. So this is what you need to convey when you talk of patient education. And when you're talking of the two common things, lifestyle control and trigger control, you're talking of getting the patient to do the same thing at the same time every day, some bit of exercise, identify the triggers if possible, look at his diet and look at sleep hygiene and control the stress levels. Particularly in this corona time, we find a lot of migraineurs, even though they are at home, even though everything else is under control, it's just the abstract emotional stress of fear of corona, which is throwing up a lot more migraine headaches than what we used to see earlier. Now, an acute treatment, which is good, is necessary for all patients. When you choose an acute treatment, what do you want to achieve? You want to give rapid and consistent relief. You want to restore the function. You want to make sure there's no recurrence, and you want to make it cost effective. What are the options you have? You have the analgesics. Here, it is important to understand that most patients respond with NSAIDs, and if you combine it with an antiemetic, then you find that the gastroparesis of migraine is addressed. And when you have moderate to severe migraine, you need to go with specific drugs, out of which the specific drugs for migraine are ergotamine and triptans. Ergotamine is now getting gradually outdated because of the additional side effects. So people are going with triptans. And unless there is status migrainosus, you do not need to have parenteral treatment for acute as an acute option. Now, the triptans came about in 1990, 1991. This is Patrick Humphrey, who gave us the first triptan, Sumatriptan. They work by producing vasoconstriction. They reduce, it has now been established that Sumatriptan reduces the level of CGRP, which is raised in migraine, and they reduce pain transmission. What are the triptans which have been subsequently developed? First was Sumatriptan, and then we had Rizatriptan and Zolmitriptan, then we had Almotriptan and Elatriptan. So what is available to us now in India? You have Sumatriptan, but you have only the tablets. We do not have the nasal spray. We do not have injections. We do have a combination of Sumatriptan and naproxen. I am not going to be giving you the trade names, but we do have these combinations. And then we have Zolmitriptan. The oral tablet is still not available to us, but the nasal spray is available. And there is an orally disintegrating form, which is now being launched. Naratriptan is not available. Rizatriptan is available. Almotriptan is available. And Elatriptan is available. Frovatriptan is not available. Now, these two drugs, which I have stroked out, Naratriptan and Frovatriptan, they are very useful drugs for the treatment of menstrual migraine. When you have a short-term prophylaxis perimenstrually, just about 5 days before the onset of periods, they were very useful, and they are unfortunately not available to us in our country. Now, when you choose preventive drugs, what are the paradigms you're going to look at? You have to set right the expectations. You have to tell the patient how long you're going to be using the prophylactics. And you have to gauge the frequency and disability and choose whether you're going to go with one prophylactic or more than one. Gone are the days when people advised you to go with only monotherapy for migraine. Sometimes patients already are on one drug when they come to you as consultants, and you have to use more than one drug. And then you have to look at the headache profile, the patient profile, if it's an obese patient or a thin patient, what is the urgency with which he wants prophylaxis, what are the contraindications and side effects, how do you choose the drug? you can't use a propranolol in an asthmatic patient. And if the patient is planning to conceive, you can't go with divalproex. If the patient has PCOD, you can't go with divalproex. What are the side effects the patient has, which you need to address when you choose the prophylactic? And sometimes drugs can be combined, sometimes drugs cannot be combined. All in all, if you achieve efficacy and tolerability, and the patient does not develop side effects, he is going to comply with your treatment, he is going to adhere to your treatment. And the current options have to be exploited to the fullest. Keep in mind the false possibility of using future options as soon as they are available. Most important, always tell the patient to maintain a diary, because if the patient comes with a calendar like this and you have the red days as the number of migraine days, you know that this patient has 3 days per month. Whereas if a patient comes with a calendar like this, you know that the patient has 1, 2, 3, 4, 5, 6, 7, 8. So he or she fulfills the criteria for chronic migraine. And that happens for 3 months in a row, then you know what you're dealing with. The question to ask patients who are willing to fill a calendar is note down the number of crystal clear days that you have, because patients tend to talk to you about only their severe headaches. They don't talk to you about their milder headaches. And then you assess the disability, the MIDAS and the HIT6. And when you choose preventives, you want to reduce the attack frequency. You want to sort of prevent the overuse of acute drugs so that medication overuse headache is avoided. And if the patient prefers, or if the patient has a severe form of migraine like brainstem migraine with brainstem or hemiplegic migraine, then you can definitely choose a preventive. But otherwise, anything more than 4 attacks a month is when preventives are indicated. And what do you want to achieve? You want to achieve so many things. The quality of life has to improve, the functionality has to improve, the responsiveness to acute treatment has to improve, and you're modifying the disease from worsening into a progressive disorder. And when you go with the principles, what are the principles? You start with a low dose and do not get to the maximum dose right away. You increase the dose slowly on follow-up. Most patients, if they are satisfied, they will follow up with you. You have to readjust the doses in follow-up. You have to give every drug an adequate trial at the therapeutic dose. Remember, these current prophylactics take up to 4 to 6 weeks to start showing their effect. And there might be, because of pharmacogenomics, a need to give a trial and error in all these patients. So therefore, you will have to tell them that there is no magic in the treatment of migraine. You got to be patient. You got to follow up correctly. And once you find the right drug which fits that patient, you will find the improvements happening. And when you evaluate periodically, look for side effects and see if there are any comorbidities, which gives you the chance to use one drug and treat 2 disorders. And all the time, keep asking the lady, if she is planning to conceive, there are certain drugs which should not be used. And also ask for any history of a pregnancy so that you take off the drugs in the first 3 months right away. So this has to be done. Now, there are guidelines for the choice of prophylactics. The most commonly used is the American Headache Society guidelines, in which the anti-epileptic drugs are there, the beta blockers are there, and the antihypertensive candesartan is coming to the forefront, and amitriptyline, which has been in the category of level B, the probably effective, I would put that in the established drugs and the category of a first-line drug, because amitriptyline helps considerably in most patients with migraine. But the caveat here is that please start with a small dose, because otherwise the patient will get sedated. Migraine patients are exquisitely sensitive to side effects of drugs. So therefore, I usually can start with 5 milligrams for about a month, and then I increase it to 10 milligrams. The optimal dose of amitriptyline for a migraine patient would be 10 milligrams. The antidepressant dosage is anywhere from 25 to 75 milligrams. So please remember that the dosage which you will be using is a very small dose. And then you have the SNRI drugs and the other drugs which also work as preventives. Get used to a couple of drugs, know their contraindications, know their side effects, and then you will be comfortable. And the first line, you could get used to using flunarizine, propranolol, divalproex, topiramate, amitriptyline, and if easily available, then candesartan. Amongst the drugs amongst the nutraceuticals and the non-pharmacological, which also can be an add-on, is riboflavin, magnesium, and you will find feverfew and butterbur is not available in India. You got to understand that the costs must be worked out according to the capacity of the patient whenever you're choosing preventers, which are to be used for a number of months. The alternative options I've talked to you about, coenzyme Q10 is also in the alternative options which can be tried out. And when you have chronic migraine, the only FDA-approved evidence-based option for chronic migraine is the use of Botox. In my experience, it works in about 60 to 70% of patients, but many times patients do not comply and do not come back to you for the second or third injection of Botox. Non-pharmacological options, very useful. Cognitive behavioral therapy, hypnotherapy, biofeedback, acupuncture works. Now, having tried all this, what is new in the 21st century? The first thing is we are looking at migraine differently now. We are looking at it as a chronic disorder, and we are looking at devices being used much more than drug options. And then we are looking at two drug groups which are used. One is the CGRP, anti-CGRP drugs, and the other is a 5-HT1F agonist, Lasmiditan, which is used in patients who have a cardiac contraindication where you don't want vasoconstriction. And the other area where you can make a difference is to have new ways to administer the same drugs which you have now. Let's talk a little for 5 minutes about this CGRP. What is going to come in the future? You need to know this because quite often a number of your affording patients have relatives abroad and they have heard or have gone to the net and come back and they tell you that why cannot I use one of the anti-CGRP drugs? So it's important for you, although it's a future option, to know about CGRP drugs. The CGRP is a neuropeptide, which is very important in the pain mechanism. It is released peripherally. It's present at all migraine pathogenesis sites. The levels of CGRP are raised in migraine. So therefore, it is a vasodilator. It is going to be the future biomarker. And what it does is it dilates the blood vessels. It also enhances the transmission of pain signals from the periphery to the center. And it can be blocked by triptans, but more considerably blocked by the anti-CGRP drugs. The first which came, there are two streams. The first which came are called the Gepants. And now what we have parenterally is called the monoclonal antibodies. Now the Gepants, two of them are going to be available. They're already available abroad. It's called Ubrogepant and Rimegepant. And people are now trying out. It is available for acute treatment. People are now trying out this option for preventive treatment. There are some differences in the molecular size between the monoclonal antibodies and the Gepants. So the Gepants can cross the blood-brain barrier, whereas the monoclonal antibodies do not cross the blood-brain barrier. And the monoclonal antibodies, they are usually more significantly effective in preventive treatment. So you don't use these for acute treatment. And they're all administered subcutaneously. One of them is administered intravenously. And they are used only for prevention. They have a very quick action. So where today your current drugs get 4 to 6 weeks to start working, within a week you find your monoclonal antibodies working, and the efficacy is sustained because half-life is prolonged. It's almost 28 days half-life. We now have 4 of them. I would not like to overload you with these names, but important it is to remember that erenumab is the one which is going to come soon. It is going to be effective against the CGRP receptor. And the other 3 drugs which are going to come in the future, but which are already available abroad, are working against the CGRP ligand. How are they administered? They are administered through an auto-injector. They can be administered through a preloaded syringe also. So this is the way you administer. The patients can self-administer these anti-CGRP monoclonal antibodies. So when there is a need to prophylactically use these, the patients take a once-monthly subcutaneous injection on their own. And you have to consider this because If there's severe disability and your current options don't work, if there is a failure with many of the current available drugs, if you have refractory migraine, if you have medication overuse headache, if you have severe comorbidities which limit the use of your current drugs because of side effects, so many situations in which these drugs are going to be more useful in the future. They are definitely better than the present for the simple reason that they are safer, they work faster, they have a higher efficacy. Some of them are super responders, 75% response rate, and they are useful in intractable situations. And what are the devices which are being used abroad? These are the future options again: transcranial magnetic stimulation, supraorbital stimulation, which is called Cephali. This is available in India. You can rent this equipment, see if it works, and then buy it. Vagal nerve stimulation, more useful for cluster headache, but also for migraine. And sometimes occipital nerve blocks help you while you take time to use the other drugs. The invasive options are used in very rare situations. Occipital nerve stimulation, we have done a couple of them, but they are for very rare situations. And when you see what else is new in the acute treatment, you're going to have a number of same drugs which are available now being administered differently through needle-free injections, through skin patches, and intranasally. You have inhalational drugs which can be administered, and then you have Lasmiditan. This is a significant advance. This is already available abroad. So therefore, these are the auto-injectors which are being used, and for Sumatriptan. And this is a 3 milligrams dose of Sumatriptan, which Dr. Reddy's labs have brought this out. This is a very useful dosage to be used, and Sumatriptan is administered fast in severe attacks. Then you have skin patches, skin delivery systems, inhalational agents, and these are all administering the same drug which is now available but through a different route. They are very useful when patients have nausea and vomiting, and this is a powdered solution of diclofenac, and this is what we already have with rizatriptan and zolmitriptan. We have the orally disintegrating strip. These are all very useful, and what we are going to see in the future is this drug called Lasmiditan. Where will it be useful? Sumatriptan is contraindicated in patients with hypertension, coronary artery disease, and this is a non-vascular 5-HT1F agonist. So in those situations where you want pain relief, where you have a non-triptan drug, this is the future option which is going to be available. And when all treatment fails, what do? You make sure there is no second problem. You make sure that you don't want your colleagues also to handle the patient. So quite often we use a psychologist or a psychiatrist to come in the picture and address the depression. Parenteral agents will help. Nerve blocks till we get time to for the current options to work. Some of the new routes of delivery when they come in, the new targets are the CGRP drugs. We have future devices and neurostimulation rarely when it's required. With all these options, I would say that migraine is a highly treatable disorder. It's not a curable disorder, but it's a significantly controllable disorder. And so therefore, with the use of current and future options, I would conclude by saying that where there is a migraine, there is a definite way, provided you exploit the options. Thank you.
So excellent presentation, sir. And this is evident with the amount of questions that we have received in our chat box. So without wasting our time, we would like to move on to the Q&A session. I request Dr. Kirti to moderate this session and take it ahead.
Sure. Thank you, Dr. Sir, this is an overwhelming experience for us. We have questions which are still coming, and they were even present at the very start of the presentation. So I'll quickly come on to some of the questions which are very interesting, which have been put up over here. Most of the questions which have been asked, you've already explained in great detail during the session. But some of the questions, for example, Dr. Ravikant is asking that is there any role of high dose multivitamins, magnesium, vitamin, alpha lipoic acid, and CoQ10 in prevention of migraine headache? Some of them you did mention during your presentation.
Yes, there is a significant role for all these nutraceuticals and non-pharmacological options in the treatment of migraine prevention, in migraine preventive treatment. And there are some patients who do not want to get into the drug options, and they ask you at the outset itself that are there any non-pharmacological options? Now, these are situations where you would combine magnesium works very well. CoQ10 is the next, riboflavin in a dose of 400 milligrams. And in fact, you would now find that there are companies which are coming out with a combination of these drugs as supplementary treatment for migraine. And although not very popular in our country, Feverfew and Butterbur are two agents which are herbals, which are used in migraine. And we don't get them, except online you can get them, but otherwise magnesium and riboflavin and coenzyme Q10 are the options which can be used in migraine patients. So definitely. And I also have read reports where intravenous thiamine has also worked in the treatment of refractory migraine. So therefore, these are all options which are correct.
Sure.
Just sorry to interrupt, sir, but sir, could you just stop the share screen, sir?
1 minute. Yeah. Yeah.
Yes, sir.
Sure. Moving on, sir, this is, I suppose, a hot question because it has been asked multiple number of times. Is the best prevention drug during pregnancy?
Yes, this is often asked at most meetings. Number one, 50% of patients in pregnancy, they have a reduction of their migraine attacks. Now, the unlucky 50%, you will have to choose as far as possible, because you do not want to get into a litigational situation. Stay away from using any drug options beyond paracetamol. You can tell the patient to use some pain balms. You can tell the patient to use some heating pads and massage treatment, and these for tackling with the acute attacks. But when patients go beyond that and you still have to use a drug option, what do you use? Now, the ondansetron is an antiemetic. Some of these pregnant patients are vomiting along with the headache. So ondansetron, paracetamol, ondansetron, and in the first trimester, you can use NSAIDs also. In terms of prophylactics, you can go with propranolol and amitriptyline. The no-no is for the anti-epileptic drugs, and always make it a point to talk to the gynecologist and then only administer, because you do not want to have a situation where you start a drug and the gynecologist know that these are allowable prophylactics. If you look at the pregnancy registry for migraine patients, even the triptan, Sumatriptan is allowed. But as I told you, stay away from litigational situations and do not do anything for which you do not have literature evidence that it works. And in the last trimester, stay away from NSAIDs. What can also be used for a severe situation of bad migraine in a pregnant patient is intravenously you can give steroids and abort the acute attacks, and oxygen also will help. So these are some of the options which you can use in pregnancy.
Sure, sir. So this is an interesting one by Dr. Basudev Das, where he's asking any latest management considerations for migraine during COVID-19 situation.
Yes, it's a good question. Now, when you're dealing with migraine and COVID-19, the first thing is, if you have a patient who is already under your treatment for migraine, there is a chance that the number of attacks might increase. There is a chance that because of subconscious anxiety states, the patient might need an additional dose of amitriptyline. So you might, in a known migraineur during COVID, you might need to increase the dosage of the prophylactics and add an anti-anxiety, antidepressant drug, and maybe even sedate the patient. Otherwise, the rest of the treatment remains the same. But what is the big trap in the COVID period is that COVID itself can present with just headache alone. So therefore, be very, very careful. There need not be fever. There need not be a drop in oxygen. There need not be other features to tell you that. So when a new onset headache comes to you in a COVID period, definitely tell the patient that in addition to the MRI, because you're doing teleconsultations of all the time, you're not going to be seeing the patient directly. So when you do a teleconsultation for a new onset headache in the COVID era, there are two things you must do. One is be aware of the possibility of this being an atypical presentation of COVID and ask for an MRI with contrast, and also ask for a COVID test. And the second thing is be watchful for development of fever. And third is be watchful of secondary complications, neurological, due to COVID, which can present with headache, such as encephalitis, sometimes strokes, sometimes vascular situations. So they are rare, but be aware of both worsening migraine as also a new onset secondary headache. So this is how you would manage in a COVID era.
Sure, sir, absolutely. Dr. Chandra Gupta has asked one symptom to diagnose migraine, which is pathognomic to migraine.
Well, the heterogeneity of migraine prevents me from giving you that one symptom by which I would say it's pathognomonic, but the most dominant, as we all know, is headache. So I would not encourage you to seek an answer to this question. It's like asking, what is your favorite antibiotic? You don't have a favorite antibiotic. It all depends on the scenario. So do not try and get an answer to this question. But the most likely one thing is, of course, as we all know, headache and accompaniments. So it's a headache plus syndrome, and headache is there in about 80–90% of patients with migraine. So use headache as the presenting feature, which is most pathognomonic.
Absolutely, sir, absolutely. So Dr. Bhupen Rabidas is asking the treatment options for refractory migraine.
Well, refractory migraine is an entity which is seen in about 10% of patients in a tertiary clinic when they fail to respond to 2 or 3 or more of the different classes of the prophylactic agents. So when you have tried the different options in correct usage of combinations by using polytherapy. So if you've gone with a beta blocker, you've added an anti-epileptic drug, your patient is already on amitriptyline, and or you take each of these drugs to their optimal therapeutic dosage for an adequate period of time, then you use the word refractory after also exploiting the nutraceuticals and the alternate non-drug options we talked about. Every patient will have lifestyle trigger control, non-pharmacological options also. So having done all that, your patient still does not improve. Then the next option, you go in a sort of layering stage. So this is the first bottom layer. So once you have exhausted the bottom layer, the next layer would be the addition of Botox, onabotulinum toxin A. So if the patient is willing, if the patient can afford, then you give him a trial with 3 injections, 3 months apart of Botox before you say that Botox does not work. So the 2 drugs which are definitely to be used when the patient is refractory are topiramate with care for the contraindications, care for the side effects, care for the cognitive effects, and botulinum toxin. If you want to buy time during this process, you can use an occipital nerve block. And after having done this, then you look at trying to advise the patient whether he can get certain devices from abroad, or he can get any of the Gepants or the anti-monoclonal CGRP monoclonal antibodies if he's still refractory. And if you cannot get any of those and you find that the quality of life is being disturbed, this is a highly disabling pervasive disorder, then you suggest the possibility of an occipital nerve stimulation, which will work in that scenario. We do have patients who have reached that stage where they have to take an injection every day. In fact, there are patients who even taken opioids every day, and we've had to give them occipital nerve stimulation to try and reduce their attacks. Sphenopalatine ganglion stimulation also will help. So this is the stepwise progress in the treatment of refractory migraine.
Sure, sir. Dr. Nityananda is asking, is there a role of neuroimaging in migraine management?
Yes, there is a definite role for neuroimaging, and that is what, when you suspect the possibility of what is called as symptomatic migraine. When you are seeing a lot of migraine patients, please remember one thing: migraine does not grant immunity from a second problem. That's where is a big trap. You're treating a patient who has migraine for 4 years, 5 years, who has already done an MRI 2 years back. He comes to you. If there is a change in pattern of the headache, that's when the trap is laid. So don't fall into that trap. Think of the possibility. There's no reason why a migraine patient cannot get a packed sinus infection. There's no reason why a migraine patient can't have meningitis. There's no reason why a migraine patient can't have tuberculomas, cysticercus, a second lesion, a pituitary lesion. So when the pattern changes, be alert to the possibility of second imaging. When you do the second imaging, always make it a point to do an MRI with contrast, never a CT scan. The other situation, when you would image, even for the first time, is if somebody comes and tells you that all the time I get migraine attacks, it looks typically like migraine. I have nausea, vomiting, photophobia, phonophobia, I have trigger links, but 100% all my attacks are on the right side or on the left side. You don't entertain migraine with side locked headache without imaging. You like migraine to come sometimes on the right, sometimes on the left. Changing sides is an important feature of migraine. So therefore, migraine with aura, you would always want to investigate. There could be a small nubbin of a tuberculoma, a cysticercus in the occipital cortex, which is giving rise to that aura. So migraine with comorbid, with aura, migraine with seizures, comorbidities like that, you will always image. So these are some scenarios in which you would image what looks like migraine. And if you're suspecting a vascular malformation, you would also go ahead. AVM headaches can sometimes look like migraine. So you would also go to the point of doing an MR angiogram in those situations. Sometimes venous thrombosis can present looking like migraine. So it's wrong to say that migraine, the index of suspicion should be high when you find that at the atypical extremes of age, you get migraine. And when you have children, if you do an imaging, you treat two patients. One is the child and the anxious parent. So therefore, it's important in children to make sure you don't miss a posterior fossa lesion by not imaging. And these are the situations when you would image.
Sure, sir. Since you were on the pediatric migraine, Dr. J.S. Kushwaha has asked, how has been your experience with pediatric migraine?
Well, pediatric migraine is both easy and difficult to treat. When it's a full-fledged, straightforward migraine with educated parents who understand, then a lot of patient education and a lot of times doing a scan. I do scan. I don't care about the guidelines, imaging guidelines. I do scan all my pediatric patients for the simple reason that we are not dealing with a treatment which is for 1 month or 2 months. We are dealing with a lifestyle correction disorder which needs medications. So therefore, parents do not accept it unless you have imaging done. Otherwise, they think that you have missed something and somebody else does the imaging. So when you do the imaging and you have a normal MRI or a normal CT scan, you get a lot of advantage. Then the choice of drugs, usually cyproheptadine, flunarizine works very well, and beta blockers can be used. And there are studies which are now looking at anti-epileptic drugs in children to treat migraine. And although the triptans should not be used below the age of 12, aspirin is something you would like to avoid. Below the age of 12, go with paracetamol. And after the age of 12, you can choose the triptans also. So children need to have their breakfast on time. You need to be careful of their diet. You need to avoid cheese, chocolates. You need to avoid the MSG. And there are a lot of Maggie noodles going on. There are a lot of Coke. So you need to be careful about all these drinks which children, adolescents, they use and take care to give strict dietary restrictions to the children, use drugs, gradually build them up, educate the parents. And a lot of pediatric migraines are not difficult to handle. And if you are dealing with a child who is in the 9th or 10th standard or 12th standard, and particularly an adolescent who is appearing for the NEET exam, crazy situation. It drives children into such a bad scenario. Please do take the help of a psychologist. I don't know where these exams are going, and now COVID has added to all the stress. So these examination situations in our country are a definite aggravating factor for migraine in children and adolescents in our country.
Um, yeah, just sir, we have so many questions, sir. So could we just have a rapid fire question round?
Okay.
And yeah, so Kirti, let's have a rapid fire question round. And the first one that has come on WhatsApp is COVID stress and migraine. Is there any relationship?
COVID stress and migraine already discussed. There is no direct relationship, but definitely COVID can aggravate. In fact, CGRP levels have been found to be high in COVID patients also. So therefore, it can be a provocative factor for migraine, but there's no other direct correlation.
So Gepants or Ditans?
Gepants or Ditans? I would go with Ditans first because they would be cheaper, they would be easier, they would be more effective. And then I would go with Gepants, but I don't have experience. So I don't know the speed of efficacy, but I think what the literature says, the Ditans would be faster than Gepants.
There are a lot of molecules, particularly, which have been asked about. So, one word, if you can, 1 or 2 words, if you can say, for example, about amitriptyline.
Amitriptyline is a wonderful drug in migraine in a small dose. 5 milligrams or 10 milligrams is enough. In fact, I feel that amitriptyline should be a part of prescription of most migraine patients because it not only works on the migraine mechanism, it also works as a good sedative, which most patients are not having a proper sleep hygiene. So it gives you good sleep for 7 to 8 hours, and it reduces the anxiety levels, which is definitely there as a comorbidity in most migraine patients. So if there are no strong contraindications, then I would go with a 5 milligram dose of amitriptyline to start with and build up the dose to 10 milligrams if required. But I would not exceed 10 milligrams in a migraine.
And flunarizine.
Flunarizine, you have to be careful about. One is the sedative potential, the chances of depression, the chances of weight gain. Now, with 10 milligrams of flunarizine, you have a long-term, used in the long term, you have a chance of encountering weight gain. So therefore, flunarizine, again, start with 5 milligrams for a month and then increase the dosage. But be careful of these side effects. If the patient is depressed, it's a contraindication. But otherwise, it's useful in children also.
Kirti, are you there or some network issue?
I think Dr. Kirti has network issue.
Kirti has network issue. Yeah, then once. I think, sir, we have covered up the maximum questions. Probably we could have just few. I think we could take it on a mail session then. I mean, you could just email them. I mean, we'll email the questions to you so you could just answer and we could then send back to the doctors.
Yeah, no.
Thank you, sir. Thank you very much for this excellent deliberation on various aspects of recent advances in migraine management. Sir, I should really say, sir, your session was really simple, crisp, and it covered all the aspects from pharmacological to the non-pharmacological, from invasive to non-invasive. Everything was been covered in such a nice way that the key messages have really been percolated well to our esteemed delegates. So thank you very much, sir, for this. And so we had, I mean, I can say that for our registration, so we had 2000 plus pan India and has witnessed today's session. So I should just say thank you, sir, for sparing your precious time and educating all of us. And I also take this opportunity to thank all the doctors for supporting our Indian patients during this COVID time. Thank you very much. And over to you, Prashant, for the final vote of thanks.
Yeah. Good evening, all. Is there an echo?
No, not at all.
Okay, fine. First of all, I'd like to say on behalf of Dr. Reddy's, all the delegates and all the members who are part of this program, take a bow because the immense effort you all do in handling the patients is just wonderful. Thank you for sparing your time. We have had almost 2,689 registrations. And Dr. Ravishankar, sir, like you're part of every IronCon, probably this number is more than an IronCon, if I'm not wrong, sir. I think your name makes these things happen when it comes to headache and migraine. So thank you all for this wonderful presence. Yes, what do I say? Like when I say sincere gratitude to Dr. Ravishankar, we know him for his content, his authority on headache. Correct me, sir, if I'm wrong, but I've probably been associated with you for almost 8 years and been hearing various programs of yours on headache and migraine. I've been simply awed by your talk always because it's very simple to understand for a layman like me. Also, it's very simple to understand. And yes, permit me for in saying so, but like it's like listening to Amitabh Bachchan in headache. Because the voice, the way you put it across, it's an authority, sir. And there's a conviction behind the words. So it really puts down the message in a very simple take home for us also. Like, yes, there is a message for Dr. Reddy's also, like we need to plan a product profile in terms of coming future. The nasal Sumatriptans or the like it's a debatable, we do have nasal Sumatriptan in the US, so probably we could be getting it here. And yes, sir, we do have Triptoma 10 milligram right now, which is in score tablet form. So like the 5 milligram will help address that initial need, sir. So thank you for your wonderful talk. And yes, I also take this opportunity to thank Dr. Snehal, Dr. Kirti, Tanuj for his like immense background work over the last 1 week and making things happen on all fronts. Would like to take this opportunity also like to thank my team, the team in the field, which is during this era of COVID has reached out to such a huge number of doctors across India and ensuring the participation, which has made this evening a wonderful evening to remember. Thank you all. And before I close, yes, thank you to our partner for tonight, that is HiDoc, a wonderful network support for a flawless 1.5 hour, close to I would say 1.5 hour of like a presentation which could happen across the country. Thank you once again. Thank you to all. Thank you, sir. Thank you for making our day.
Thank you, Prashant, for those kind words. And let me thank all of you. Thank you, Dr. Snehal, Dr. Kirti, and Tanuj, who has been coordinating, like you said, in the background, but he has been doing an excellent job. And thanks most importantly to all of you in the audience who have patiently been hearing this, because a speaker is only as good as his audience. So thank you so much for being around. And I enjoyed delivering this talk as much as you liked hearing it. Thank you so much.
Thank you, sir. Thank you for making our day.
I think we all could log out now. So thank you. Stay home, stay safe.